स्टार्ट करें?
सर वो ऑप्शन डिसेबल कर दीजिए।
हाँ हाँ वो मैं कर रहा हूँ। ओके सही है।
यस सर, स्टार्ट कर सकते हैं सर आप।
ओके जी, sorry for the delay. Diseases of the skeletal muscle. Now, a lot of, as you will see, basically the function of skeletal muscles is basically movement and providing support. So a lot of diseases of the skeletal muscle will present with weakness or paralysis, varying degrees depending on the severity, the type of disease. And that is the usual presentation of disease of the skeletal muscle. That's common hallmark. Now, just visiting the physiology a bit. This is the motor end plate or motor unit, which is consists of a neuron, an axon, and then the motor end plate and the muscle itself. All right. So, because skeletal muscle diseases are closely linked with the neuromuscular unit, so a lot of neuronal diseases will also present ultimately with muscle weaknesses. So there's a lot of overlap with these kind of diseases. Now, just like other organs of the body, like kidney and liver, the response of a muscle to injurious agents is fairly limited because of the unique structure it has. So the kind of changes that we see in muscles following injuries are either segmental necrosis, which is the dissection of a portion of the individual myocyte, or you might see vacuolation, which is alteration in structural proteins or organelles and accumulation of intracytoplasmic deposits. So you would expect these kind of changes to be seen in degenerative disorders or in metabolic disorders, where things start getting accumulated or being formed abnormally within the myocytes. Regeneration occurs when satellite precursor cells proliferate and reconstitute destroyed portions of the fiber. But regeneration in the muscle is a slow phenomena, and it's not a phenomena through which muscle usually regenerates or recovers after injury. But there's mild, rare, in rare instances, there might be some regeneration of muscle fibers. Then you see fiber hypertrophy, which occurs in response to increased overload, either in setting of exercises or in pathologic conditions in which muscle fibers are in. Now, although this isn't, it's more of a neuropathy, but I'll cover it quickly because it's an important disease. Guillain-Barré Syndrome or acute inflammatory demyelinating polyradiculoneuropathy. We'll be referring it to as GBS. It's a life-threatening disease of the peripheral nervous system, characterized clinically by weakness beginning in the distal limbs, but rapidly advancing to affect proximal muscle function. This is also called ascending paralysis. And histologically, what we'll see is there's inflammation and demyelination of the spinal nerve roots and peripheral nerves. But the muscle is tight, there's no inflammation in the muscle, but because the nerve, as I showed you at the beginning, because of the unit, there's inflammation of the motor neuron, the axon is being attacked, so you see weakness in the muscle. GBS is an acute onset immune-mediated demyelinating neuropathy, and approximately two-thirds, around 70% of the cases are preceded by a flu-like illness. Infections with Campylobacter jejuni, CMV, Epstein-Barr virus, Mycoplasma pneumoniae, or sometimes is a history of prior vaccination 1 week or 2 weeks before the onset of GBS is you often find a history of vaccination, but it's not routine. But sometimes there has been some association with vaccination. So the theory being that these organisms trigger formation of antibodies that attack the myelin sheet of the or cross-react with the myelin sheet of the axons. Obviously, because myelinated fibers are affected, so the large reflex pathways and the large nerves are more affected as compared to the smaller nerves. and because the myelinated fibers carry fast track movements or fast impulses, vital impulses, those are the first to go. So lymphocytes from individuals with GBS have been shown to produce demyelination in tissue cultures of myelinated nerve fibers. And also, besides self-acting lymphocytes, you find circulating antibodies, which also, that is the rationale of doing plasmapheresis in these patients. It's in raised hand. जी बेटा, roll number 63 ने शायद raise hand किया था. Any question? Roll number 63. No questions. Okay, I'll proceed. Okay, so that is the rationale of using plasmapheresis in these patients to reduce the load of the circulating self-acting antibodies. Okay. Now, the clinical picture is dominated by ascending paralysis, deep tendon reflexes, usually disappear early in the process, as I told you, because it's the nerve fibers that are more severely affected. So movement or impulses that travel very fast go out are affected more severely. Nerve conduction velocity is slowed because of multifocal destruction of the myelin sheath. तो वो जो roads of Ranvier हैं वो डैमेज हो जाते हैं, तो जो एक्शन पोटेंशियल है उसकी मूवमेंट उतनी फास्ट नहीं रहती जितनी एक्सपेक्टेड होती है. Elevation of CSF protein due to inflammation and altered permeability of the microcirculation within the spinal roots. तो तभी डिफरेंशियल्स में जो है वो कभी कभार क्या कहते हैं meningitis भी आ जाता है, एटलीस्ट इन इनिशियल स्टेजेस. ऑब्वियसली meningitis में पेन ज़्यादा होता है, नेक्रोसिटी वगैरह होती है, इसमें नहीं होती. Obviously, because there's paralysis, patients need to spend long times in the ICUs and might need intensive ventilatory support. But fortunately enough, because of increased availability and higher quality of respiratory care in intensive care patients, and because of advent of understanding the pathophysiology and having plasmapheresis, the mortality has really gone down. It used to be more than 50% in 20-25 years back. Okay, but unfortunately, because of the demyelinating process, sometimes patients have permanent damage, and they might have some degree of disability, long-term disability. We just skip this. Now coming to muscle pathology, different conditions can produce abnormalities in the skeletal muscle. Neurogenic atrophy of the muscle is caused by disorders that affect the motor neurons. Now, I'll cover this later on. We'll come to muscular dystrophies. Now, muscular dystrophies are a heterogeneous group of inherited disorders of muscles, often beginning in childhood, that lead to progressive weakness and muscle wasting. So, the typical presentation of the two more common dystrophies, Duchenne's and Becker's muscular dystrophy, is that because they're X-linked diseases, generally, almost always they present in males. Typical presentation is depending if it's Becker's or Duchenne's. Duchenne's is more severe, so it presents a bit earlier. It will miss their early milestones, especially the motor milestones. Ultimately, they will become weak with dependence for wheelchair, and by their teens, unfortunately, in Duchenne's they die. In Becker's, they survive into late, like the early 20s or late 20s. You will see some survivors, but ultimately they also die because there's wasting of the muscles and death of the myocyte, and that causes ultimate paralysis, weakness of the diaphragmatic muscles, and patient unfortunately dies. Histologically, in advanced cases, muscle fiber undergo degeneration and are replaced by fibrofatty tissue and collagen because, as we see pathophysiologically, the dystrophin protein is necessary for the survival of the individual myocyte. In this case, there's abnormal dystrophin or there isn't enough dystrophin, so the individual myocyte is unable to survive and it dies through apoptosis and ultimately is lost. And that tissue or that space is then replaced by um, collagen and fat. And this feature helps us in distinguishing dystrophy from other myopathies because in other myopathies you will either see inflammation or you will see atrophic muscle fibers. But in this, ultimately, there's complete loss of the uh, individual myocytes. Now, of the X-linked muscular dystrophies, the common ones are Duchenne's and Becker's dystrophy. Duchenne's muscular dystrophy is the most severe and common form of muscular dystrophy with an incidence of about 1 per 3,500 live male births. Duchenne's becomes clinically manifest by age of 5 years. It leads to wheelchair dependence by 10 to 12 years and thereafter progresses relentlessly. And generally, patients don't survive into their 20s with this. With Becker's muscular dystrophy, the onset is slightly late. You'll see patients initially presenting in 8, 10 years, 12 years of age. They do become wheelchair bound by their late teens, and ultimately, as I told you, by 20s, late 20s, they unfortunately do die. Okay. Both Duchenne's and Becker's muscular dystrophy are caused by abnormalities in the Duchenne muscular dystrophy gene, which is located on X chromosome, region 2, short of region 2, band 1. Duchenne's is one of the largest human genes, spanning 2.3 million base pairs. And I'll come to this in the end, why this is important. Two-thirds of cases are familial, remainder are new mutations. Uh, in affected families, females are carriers, obviously because it's a X-linked disorder. Are clinically asymptomatic, but often will present when obviously when some individual is a boy or the son is affected, and workup is done. If you check the serum creatinine levels, it may show slight elevation and mild histologic abnormalities may be seen in muscle biopsies, but generally they are asymptomatic. Female carriers and infected males who survive into adulthood are also at risk for developing dilated cardiomyopathy. This is more true in Becker's. Usually, Duchenne's, unfortunately, they don't generally survive into adulthood. Dystrophin and dystrophin associated protein complex form an interface between the cellular contractile apparatus and extracellular connective tissue matrix. तो जो मसल का स्ट्रक्चर है ये ट्यूशिन जो है उसको होल्ड करने में हेल्प करता है उसको सपोर्ट में हेल्प करता है or if it is lost what happens is the support between the endoplasmic reticulum and the contractile apparatus and the outer membrane it is lost and because it is lost the muscle is not able to survive and ultimately it dies. Muscle biopsy specimens of individuals with both Duchenne's and Becker show little or no dystrophin by both staining and Western blot analysis. So basically molecular techniques होती हैं और special enzyme histochemistry होती है जिसके through हम ये डिटेक्ट करते हैं कि डिस्ट्रोफिन मसल्स के अंदर प्रेजेंट है कि नहीं है. तो ड्यूशेन्स में और बैकर्स में दोनों में या तो कम होता है या सिरे से नहीं. Boys with Duchenne's are normal at however, walking is often delayed and indications of muscle weakness are clumsiness and inability to keep up with the peers. सही है तो थक जल्दी जाएंगे स्लो होंगे उठ जैसे बच्चे हैं तो कब देर माँ करेगी कि चलना बहुत देर से शुरू किया तो these are the kind of present signs or symptoms that present early and you can pick this disease earlier on in life. Weakness begins in pelvic girdle then extends to the shoulder girdle. Another feature that we see in Duchenne's and Becker's is pseudohypertrophy of leg muscles. तो देखने में जो है ये इनकी जो पिंडलीय का ये मास है अच्छा लगता है. They seem thick, but they are thick because of them being replaced by fat rather than actual muscle. So अगर biopsy करेंगे तो it will show largely fat and it will not show muscles, but एक grossly it looks कि जी जो muscle mass है वो leg का सही है, so hence the name pseudohypertrophy. Later on in life, patients will present with heart failure or arrhythmias because heart muscles are also involved. It's especially Duchenne's and to some extent Becker's also. There is also some degree of cognitive impairment, and sometimes it is severe enough to qualify as genuine mental retardation. Serum creatine kinase is elevated during the first decade of life, but returns to normal. This happens because after reaching crossing 10, पीछे इतना मसल मास रहता ही नहीं है कि वो जब डैमेज हो तो वो स्पिल ओवर हो creatine kinase in the serum and you can detect it. तो क्योंकि पीछे का रिजर्वॉयर खत्म हो जाता है creatine kinase का because of extensive and muscle mass loss. इसलिए after 10 years of age or 12 years of age, if you do serum creatine kinase levels, they will not be raised. That ultimately results from respiratory insufficiency because of the weakness of the respiratory apparatus muscles, which causes ultimately pulmonary infections and in some cases arrhythmias and cardiac decompensation may also result in death. Gene therapy has received a greater deal of attention, but unfortunately, as I told you, okay, it is one of the largest genes that we know of. So gene implantation or the genetic manipulation has been very difficult to achieve in this case. So this is called the Dover's maneuver, and if you tell the child from lying in a prone position to get up because of the marked weakness of the pelvic girdle, the child will have to take support from the shoulder girdle or the muscles of the upper limb to get up, and then the boy gets up. All right, and ultimately, unfortunately, the child becomes wheelchair dependent, and because it's not a laughing metaphor because most of the cases are familial. Uh, this tends to it tends to affect the family, the male child. So it's जो स्टिग्मा है सोसाइटी में वो बहुत बुरा होता है क्योंकि कंप्लेन इसकी जी लड़का होता है 8-10 साल का होता है कमजोरियां शुरू हो जाती हैं व्हील चेयर बाउंड हो जाता है और अल्टीमेटली 12-15 साल की तक वो अनफॉर्चुनेटली कर जाते हैं एंड दिस बिकॉज इट्स एक्स लिंक्ड डिसऑर्डर तो सिर्फ लड़कों को इवॉल्व कर रहा होता है तो इट्स बिग ट्रॉमा फॉर द फैमिली they keep on losing the male child by 10-12 years of age. And obviously, taking care of these child it's a difficult task because of their disability. Other less common forms of muscular dystrophy share many features of Duchenne's and Becker's, but have distinct clinical and pathological characteristics. Some of these muscular dystrophies affect specific muscle groups, and diagnosis is based largely on patterns of muscle weaknesses. Several autosomal muscular dystrophies, however, affect the proximal musculature of the trunks and limbs, similar to the X-linked muscular dystrophy, and are therefore called limb girdle muscular dystrophies. Obviously, they are less common and less severe in severity as compared to Duchenne's and Becker. Now, antibody-mediated disease of the neuromuscular junction. Now, ये जो disease है, unlike GBS, this is a disease of the muscular system, skeletal muscle. It is also an autoimmune disease and usually associated with autoantibodies directed against the acetylcholine receptors. Acetylcholine receptors. Prevalence is of around 150 to 200 per million and shows a bimodal age difference. So younger age group में आती है and then there's a peak in the later age group in older adults. Female to male ratio is 2:1 in younger adults. In older adults, there's a male predominance. तो ये अच्छा याद करने वाला केस है. It's one of the subset of this disease is more common in males. When generally autoimmune diseases are more common in females. About 85% of patients have antibodies or autoantibodies against the post-synaptic acetylcholine receptors. So the motor rate है actually area under attack होता है. Remaining patients have antibodies against sarcolemmal proteins or muscle-specific receptor tyrosine kinase. End result होता यही है कि ultimately because of the problem in transmission of the impulse from the nerve to the ultimate to the contractile apparatus of the muscle, there is resulting muscle weakness. Anti-acetylcholine receptor antibodies lead to aggression and degradation of receptors and also to damage of postsynaptic membranes through complement fixation, which induces inflammation. Autoantibodies directed against muscle-specific tyrosine kinase interfere with trafficking and clustering of acetylcholine receptors within the sarcolemmal membrane. As I told you, the net effect being decreased acetylcholine receptor function and ultimately muscle weakness. There is a strong association between pathogenic anti-acetylcholine receptor and autoantibodies and thymic abnormalities. Isliye, there's a very strong association with thymomas and so much so that therapeutic intervention and removing the thymoma or removing the hyplastic thymus gland will result in remission or the disease being controlled. That is a very viable therapeutic option in patients with myasthenia gravis. An additional 30% of patients will have thymic hyplasia. 10% of the patients of myasthenia gravis suffer from thymo, and additional 30% will have thymic hyplasia. So it's supposedly the active thymus gland or the action of the thymus gland results in formation of self-correcting antibodies against the acetylcholine receptor. Patients with acetylcholine receptors antibodies typically present with fluctuating weakness that worsens with exertion. क्योंकि जितना ज़्यादा होता है कि receptors under attack हो रहे होते हैं और जितना ज़्यादा यूज करेंगे वो receptors exhaust हो जाते हैं and ultimately जो available receptors हैं to carry out the action potential are depleted. तो पेशेंट जितना एक्सर्शन होती आती है उसकी वीकनेस बढ़ती आती है. So generally the typical presenting complaint is that as the day progresses the degree of fatigue or weakness increases. Diplopia and ptosis due to involvement of extraocular muscles are common and distinguish myasthenia gravis from myopathies. जिसमें generally larger muscle groups जो हैं वो ज़्यादा involved होते हैं. Patients who develop generalized disease show अच्छा ये देखो डिप्लोपिया टोसिस इसलिए भी ज़्यादा होता है क्योंकि जितना ज़्यादा मसल एक्टिव और फाइन मूवमेंट्स करेगा उतना ज़्यादा ये रिसेप्टर एक्शन पोटेंशियल ज़्यादा जनरेट हो रहे होते हैं तो ये रिसेप्टर जो है वो जल्दी एग्जॉस्ट होते हैं. तो फाइन मूवमेंट वाले मसल्स हैं वो जल्दी एग्जॉस्ट होंगे. Patients who develop generalized disease show weakness that can also be so severe as to require mechanical ventilation. Okay. And diagnosis is based on clinical history, physical findings, identification of autoantibodies, and electrophysiologic studies. ये electrophysiologic studies वही देखने के लिए कि action potential generate हो रहा है नहीं हो रहा है क्योंकि बहुत देना कि because it presents as muscular weakness, there's a lot of overlap with other myopathies So not only these, sometimes you might even have to, in some complicated cases, you might even have to do EEGs to distinguish it from other neuropathies and myopathy. Now, acetylcholinesterase inhibitors that increase the half-life of acetylcholine are the first line of treatment. Plasmapheresis and immunosuppressive drugs can bring symptoms under control by decreasing the antibody titers. And as I told you, those cases that are associated with thymic hyperplasia or thymus often respond well when you remove the overactive thymus. Because that is the source of the production of the abnormal antibodies. Okay. Any questions? कोई questions? सब कुछ क्लियर है? शुरू में किसी ने हैंड रेज किया था, उसका कोई क्वेश्चन था? myopathies and myasthenia gravis. बेटा देखो, एक तो myasthenia gravis में एंटीबॉडीज जो हैं वो अगेंस्ट एसिटाइलकोलिन रिसेप्टर, तो यू कैन डू दैट ऑन serology. उसके अलावा in some cases you might usually to myasthenia gravis में तो एंटीबॉडीज मिल जाती हैं, शॉर्ट हिस्ट्री होती है, क्लियर हो जाता है, मतलब नॉन इन्वेसिव टेस्ट से हो जाता है यूजली, इलेक्ट्रोफिजियोलॉजिक स्टडीज आप करते हैं तो उसमें अंदाजा हो जाता है. बट इन सम केसेस यू माइट complicated cases you might need to do a biopsy. Biopsy में in myopathies you will see inflammation of the muscle depending वो किस जगह पे होता है. myasthenia gravis में usually motor head के रीजन में होती है, कोई बहुत ज़्यादा usually inflammation बहुत होती नहीं है. So basically it's clinical. Serological testing करते हैं, जिसमें depending on in myasthenia gravis you will have specific antibodies that raise. Myopathies में वो specific antibodies raise नहीं होंगे. And then clinical history examination. Those antibodies are found against the Chinese receptors. Any other question? I think there are no more questions. अच्छा, उसमें GBS में कुछ चीज समझ में ना आई हो, उसका तो आप लोग का एक सेशन भी हुआ है ना, उस पे एडमोडो पे या उस पे? सही है वकास?
Yes, Doctor sir.
there are no more questions, so
Okay, sir, आप end कर सकते हैं. Thank you so much, sir.
thank you.